Yeah, if you want to let Howard go first, that's fine, Jeff.
Okay. There we go.
Okay, the first case, highway speed motor vehicle crash. And this is a pretty dramatic case of acute traumatic aortic injury. So let's say start here, where we usually look for that. And you can see the nature of the aortic mural injury. But of course, in addition to that, going very, you can see there's a lot of intraluminal thrombus as well. And then when we go upwards, we can appreciate that there is intramural hematoma here in relation to the distal aortic arch, the origins of the brachiocephalic arteries, and the intramural hematoma in relation to the left carotid artery goes up a fair ways, as you can see there. So IMH, impressive, a very impressive mural injury, and thrombus, a lot in that aorta. And here in the abdomen, at least in relation to the, where am I? Yep. Left kidney is perhaps an evolving infarct from an embolus related to the thrombus associated with that aortic injury, at least finding certainly consistent with that. Has anyone seen a complex of injuries quite like this?
No, that's pretty severe. I mean, I've seen some thrombus before, but it's quite an impressive injury.
Yeah. Of course, they did put a stent in here to manage that portion of the injury. Yeah, pretty dramatic case. This story here starts in 2015. The patient was evaluated for lung disease. A colleague did report the presence of an abnormal opacity in the posterior and basal right hemithorax, did recommend further evaluation of it with chest CT. That wasn't done. So now let's fast forward or slow forward. Many years. Let me try and fix that part up. Here is what it looks like now. Obviously, it's increased in size, and it has a convex interface on its inner portion. I do wonder whether here there is some displaced extrapleural fat and potentially some relatively big systemic vessels supplying that as well. So slow growth over many years of a large, now large circumscribed mass. I think we probably, if I had to take a poll, we would go for things like a solitary fibrous tumor, right? Anyone want to take a guess at something else unusual? Something that ought to be a solitary fibrous tumor, for example.
Some weird neural tumor.
Neural tumors possibility. This isn't
unusual. That. I mean, you can get pleural lymphomas as masses.
Yeah, lymphoma, plasmacytoma, something along those lines.
Yeah, something that's slow growing, right? Good. Yep. Isn't that interesting? An extranodal marginal zone lymphoma. based on a CT-guided biopsy. So that's really interesting. I don't think I've seen one. It looks to me like it actually is maybe extrapleural in its location. So that's
Yeah, it's
really
a little
interesting.
more, for its size too, Howard, it's a little more homogeneous than the typical fibrous tumor, given how big it is.
Okay, so maybe.
But I still think it's a fibrous tumor is still a very reasonable initial consideration, though.
Yeah. Oh, I see. There's a bit of pleural fluid associated with it down here. Good. So that's really interesting. Let's do this one. Wait. I want to do another one first. This is from an outside institution, ostensibly a lung cancer screening CT. And here is one relatively large lesion in the left upper lobe. And I'm going to show you, in addition to that, let me first just show its appearance on the slightly noisy image there. So it's lobulated, fairly homogeneous in attenuation. A couple small lymph nodes in the mediastinum adjacent to it, none of which is particularly enlarged. Now, there's some interesting findings, and I'll show you a corresponding PET in a moment. Here, in relation to airways, bronchi, in the right upper lobe, and the bronchial lumens are filled with material. And then if I go down here, a very similar finding in relation to airways here, also intraluminal material pathology in the lumen and distending the lumen of airways extending out. So let me bring in the PET-CT to show you that all these lesions are rather hot. So here is the spherical opacity in the left upper lobe, and here you can see that that one bronchus is rather hot, and so is this one right there. So this is really unusual. Do we have completely separate pathologies, the left lung being one pathology, this being another pathology? Really hard to say. So of course, this will be very unusual for a primary lung cancer, and it isn't. So here's the pathology report of the biopsy of the left upper lobe lesion. It is a small B-cell lymphoma. I don't know what the etiology of the right lung lesions are. I suppose one could have multicentric lymphoma, but the big lesion turns out to be a lymphoma. So I don't know what else to say about it. It's just very interesting lesion.
Very odd.
Lung cancer screening CT. What does one say?
So I wonder how one puts that in the registry, because it's not technically a lung cancer, but you diagnosed a malignancy.
Yeah. Yeah, very curious. Would anyone think of anything else in particular about these airways? Of course, one can make a diagnosis, but it looks like these airways are not just filled with stuff, but they're expanded. The lumens are expanded with something, and in two areas.
Yeah, I mean, it's not this case because there's other findings that aren't entirely consistent with it, but I've seen amyloid, the one that involves the bronchi and the larger airways, have this appearance, but it's usually more central stuff as well.
Wow.
I have a couple cases of I can't remember if it's tracheobronchial. It's not tracheobronchial amyloid. There's one that involves the more distal airways too. Anyways.
Yeah. So we may never know. Unless in therapy it goes away, then you might say, well, we'll never know for sure. Unless, and I'm sure they're not going to biopsy that. They're going to treat the lymphoma and then see what happens, at least initially, right? Okay, here is the last case. So bringing up a chest x-ray on a particular day, and as I'll show you in a moment, the history that I received for this case was cysts on the jaws, cysts on the jaws. And it turns out that the patient went to a dentist and had presumably a panorex or something equivalent to a panorex, which accounts for the cysts on the jaws. And then I'll give you a moment to look at that. I will tell you while you look at that the patient did have a clavicle imaging examination some weeks or months before this, or weeks before this, that was read as normal, which, as you might expect when you look at it a second time, is not normal. So here are the clavicula.
How old is this patient, Howard?
This patient is 50-ish or something.
Okay.
So what would you guys go for? Cystic lesions, lytic lesions, pathologic fracture, cysts on the jaws?
And proximal left humerus.
Yeah.
And the humerus right there without a history of a cancer at this point in time. Here you'll see the FDG avidity in those lesions as well as other bones like the manubrium there. And I think I saw some in ribs like right there. So yeah, the most likely diagnosis in the absence of a history of an extrathoracic epithelial tumor is exactly what this is, which is multiple myeloma. So somewhat interesting presentation of that lesion. So we suggested multiple myeloma, and that's what it turned out to be. All right, those are my cases, Jeff.
All right, thanks, Howard. Let's see, Travis, you want to go now?
Sure. All right, you should see a radiograph, and
Yeah.
the PA view doesn't really do much. This is a patient who's had a bilateral lung transplant. They don't have the typical clamshell sternotomy wires. It was the lateral view that caught my eye when I was looking at this, though, and I'll let you look for a second. And is there anything that...
Subcutaneous emphysema in front of the lower sternum.
Yeah, exactly. That's what I saw. And I was like, oh, that looks, why is there gas anterior to the mediastinum or anterior to the sternum or what's left of the sternum? This is an old radiograph, still post-transplant, and there you can see there's nothing there at that time in that region. And I was able to dig up a CT around the time of that prior radiograph. And there's no air in there at that time, but you'll see some strange little vessels, and said vessels communicate with these vessels and are actually omental vessels. So what do you think?
Is it some kind of weird like hernia from the clamshell?
Well, yeah, that's what I thought. And now when you look at the sternum, you can actually see that the portion, what I didn't know at this time was they actually had a debridement for osteomyelitis and mediastinitis posterior clamshell sternotomy. And this was actually an intentional omental flap that was brought up to help heal the sternum. But then the patient more recently, I called the surgeon, and the patient more recently had developed pain and new tenderness or new sensation there. And this is bowel that's now herniating through that omental, the omental flap that they had used.
That's
so
cool.
I think, yeah, so something happened, and they're going to go in and repair this and reduce the bowel that's up there. But yeah, I thought at first this was just some sort of unintentional iatrogenic hernia in the subcutaneous tissue, but it turns out it was actually intentional to help repair their prior mediastinitis.
Okay,
So,
that's it.
Yeah, and I think maybe, not that you'd think you'd call it prospectively, but I think some of that bowel is there. And now, yeah, Howard, as you see, there's like little stool balls in there too. So
yeah, that wouldn't have guessed right off.
Yeah, so it's just an interesting observation that I saw on the lateral and made me go digging through the chart, and something I hadn't seen before.
Yeah, it's kind of akin to the transdiaphragmatic omental fat transpositions for bronchial dumps that some surgeons do. This one's sort of analogous. It's just more superficial. Yeah. Oh,
So
wow.
this woman, so this case, this was over a year ago, and there's a nice little cavitary lesion in the right upper lobe. And she has had a few CTs. And as you can see, it's a fairly discrete cavity, and there's a few other small little satellite nodules. She has other underlying emphysema. And this is not tuberculosis, but she has had several positive cultures for MAC. And so this was last year, and I'll show you on soft tissue windows, discrete cavity. This was just over a month ago. And at this time, she's having occasional hemoptysis, and you can see that this cavitary lesion's getting a little bit bigger. And she's got presumably additional foci of hemorrhage in the right lung that she's aspirating or just spreading through airways, and then infection in her left lower lobe as well. But that CT, I'll pull up this one next to it and show you. So this was this is a month later, and she's now having worsening hemoptysis. And look what we see now. Observation was made that there's a little extra contrast there bulging out. And she goes downhill fairly quickly. As you can see on this radiograph, she's now intubated, and there's some airspace opacity surrounding that, and presumably stuff in the airways and in the lungs. And then this is the CT just 3 days later, and you can see how much this pseudo-aneurysm has enlarged right here. And she's having hemoptysis, and she's intubated for airway control and whatnot. But they actually were able to successfully embolize this. And I'll show you the post-op radiograph first, and they've used onyx to embolize this. And you can kind of see the casts of the pulmonary arteries next to this. And I have some fluoro images as well. So I don't know if you can call it a Rasmussen aneurysm since it's not tuberculosis, but it's certainly a mycotic pseudo-aneurysm from infection. We kind of have the before and after, and you can see here this thing filling on these selective angiograms, and then they just got more selective, and then we're able to embolize this.
Yeah, good job.
Yeah,
That's cool.
so I thought it was a good observation on this CT in particular, where there was just a subtle new blush from that subsegmental artery that was traversing the wall of that.
Could you go to the second CT or the one with the bigger pseudo-aneurysm? It almost looked like you could see some blood in the cavity, but maybe
This
not.
oh
Yeah, I was
the one
where
the larger.
Yeah, right there. You can see some contrast.
Yeah, a little bit of contrast.
That's kind of cool.
Yeah.
Oh, yeah. Good eye.
Yeah.
Nice example of the fibrocavitary phenotype of MAC, which is very similar to TV.
Yeah, the classical form, I guess.
Yeah, as opposed to the other. This patient was emphysematous also.
Yeah. So this is this is the third one of these I have. I've talked to some other people that haven't seen this before, and I can't remember if anybody else has shown these or if I've just happened to see 3 of these. But this is, does anybody want to guess the history of this or know from prior ones who've shown like this?
Is it a dental patient?
Yep.
Yeah, we
so
had
this
one
is,
here.
Yeah. This is the third drill bit that I've seen aspirated, and they're all the same story. They're just people that are undergoing routine dental procedures, and I guess the bit just comes loose, and then they attempted to suction it out, but it had ended up in a, and you can see this guy's otherwise young and healthy, but in this case, in the, looks like lateral basal segment, there's a little surrounding, ground glass. I don't know if there's a little hemorrhage there, if it's just some secretions and inflammation, but they were able to successfully retrieve this via bronchoscopy. But yeah, we've seen, I don't know, we have a whole case series now, Jeff, if we should put these together. Not that it would be that interesting, but
We
they
have
all
to
look the
tie
same.
in like actinomycosis and aspirated teeth.
Yeah, right. Yeah, but I showed I've shown a couple of other people that hadn't seen this before, but yeah, I look back and I've got 2 other ones that I've seen in my server. All right, now this is the zebra. This is a case that's made its rounds at Duke in several different venues. So this woman is 47, and when I first saw her, she was presented at our ILD conference for a question of emphysema versus cystic lung disease. And you'll see at this time, this is a couple of years ago, and I'll go through some of her history, but she has a bunch of little, just ill-defined central lobular ground glass nodules, and then cysts, what I think are cysts. I think some of these clearly have walls, and let's see, I've got a sharper reconstruction here, and you know, some of these look like they have nice, well-defined walls. And by the time she'd gotten to us, she'd had the extensive Lamb workup negative, Sjogren's workup, everything else negative. It's, you know, it's not bird hog Dubé, but these ground glass opacities turn out to be kind of fleeting, and the cysts, you know, kind of do get a little bit worse over time. So there's one CT. Here's a few months later, all the ground glass and the inflammation in her lungs is completely gone, and then it gets worse again, and she has symptoms again, and these kind of relapse. These symptoms kind of relapse. Now you can see she's got more ground glass opacities, and by this time they've done a surgical lung biopsy, and that's where diagnosis, well, that's where they said that the outside physician actually said this was emphysema, and our pathologist looked at it and saw a bunch of lymphocytes and thought it was more likely to be something related to a connective tissue disease. But she has a crazy diagnosis that has been, after a couple of years, was finally made, and her history is incredibly extensive. Actually, let me find her report, and I'll just show you, because I think this is a fascinating entity that I was unaware of. If I can get her report. Oh, I've got it here. Come on. I had it open. So anyway, she's had, for the past year, she used to be an avid runner and has now had like severe, intermittent bouts of like sinusitis and severe throat pain, rashes, severe dyspnea, coughing, other symptoms. Stop sharing for a moment while I try and find this.
Does she get urticaria? Urticaria?
I don't know if urticaria is one of the symptoms. Why do you ask?
Well, there's an entity called hypocomplementemic urticarial vasculitis that can produce what look like lung cysts. And you mentioned the rash and sort of the allergy type of symptoms. That's what I was wondering about.
No, so here it is, and so 49, and the key finding was they finally found that she had like high levels of Epstein-Barr virus viremia. And as you can see, like fever, fatigue, total blockages of her sinuses, consistency of rubber cement, excruciating throat pain, blisters, fatigue, weakness, and this is relapsed and remitted. And what's interesting is they actually tested her, they went back and tested the lung pathology, and all of these T cells along the bronchovascular bundle stained for EBV positivity. And so this is an entity called chronic active EBV infection. And presumably these lung cysts are secondary to the EBV, it's end organ damage from the Epstein-Barr virus. And this, and this has involved her marrow. It's not clear that there's other end organ involvement, but the only real treatment for this is stem cell transplant. For whatever reason, she cannot clear Epstein-Barr virus particles like people that typically get infected. And this is an entity I've been reading about, and these patients just have in here basically infiltration of organs by EBV positive lymphocytes. In her lungs, when they showed the stain, they're all over the place, which was really interesting. I've looked this up, and there's sparse case reports of lung involvement. It's usually the ground glass opacity, but nobody could find, I've never found anything on cysts, but I presume it's just, destruction of lung.
So were the cysts permanent, or did the cysts come and go?
The cysts are permanent, and I can show you, this was the original study, and these little holes, and I think it's why there's so much problem. Maybe they're just like pneumatoceles or holes, for lack of a better term, from lung inflammation and destruction. But on her most recent study, even I think this expiratory view shows it pretty well, that these persist, and arguably maybe a little bit worse. But the rest of her workup has been entirely negative, and all of these symptoms just coincide or can be explained by a relapsing, just chronic active Epstein-Barr virus infection.
Do you think it's plausible to think that somehow these lymphocytes that are affected proliferate and also deposit protein in the lung, like light chains, and then the cysts?
There was no light chain or amyloid. They stained for all of that.
Yeah.
I know, that's, because we have the path, and it's been reviewed in several conferences, and it's been sent to several different institutions. So but that's what I was thinking too. But I think it must just be that it's the relapsing nature of this inflammation and probably just end organ damage from this, or resulting in cysts.
Gosh, that's perplexing. Wow.
Yeah, but it sounds like a terrible disease too, and it doesn't always affect the lungs, but it certainly is in this case based on the stains, and so that's why they're just with her symptoms and her bone marrow and lung involvement, they're considering stem cell transplant.
Wow.
So, all right, Jeff, I'll stop there.
Right. That was cool. All right, let's see. Who wants to go next?
I can go.
All right.
I'll just show this case because I had it up. So this was a guy who 2 weeks after his first COVID vaccine came in with kind of flu-like symptoms, feeling ill, went to urgent care. I'm trying to find some good images. Guy wasn't holding his breath at all. Went to urgent care. They did an ECG. He had ST elevation. Was sent to us. They did a full workup. Cath was negative, and then he was in heart failure. I think his EF was like 35%, 40%. You could see subepicardial enhancement here, and you can see the RV, the extent of RV enhancement on the 4-chamber that I showed here. And there's multiple other areas of enhancement. There's some endocardial enhancements, maybe some extent transmural. Anyways, they did a biopsy, and they actually wrote this up. They did a biopsy, and this was giant cell myocarditis. There's no real way to differentiate giant cell from any other cause of myocarditis. And then they did an electron microscopy, and they found these tubulo-reticular inclusions in the capillary endothelial cells in the heart, and they supposedly that's also associated with COVID-related injury. Now, interestingly, it's associated with a whole bunch of other injuries. So they say, oh, it can be seen in COVID, but it can also be seen with lupus or a lot of other injuries, and as can giant cell myocarditis. But point being, everything else was negative. So presumably this was a case of giant cell myocarditis from the Pfizer vaccine. So not the most beautiful imaging, but just, and it's hard to always, I mean, it's really hard to prove that. You really can't. You just assume that that's the cause, given the temporal relationship. This was a trauma case we had over the weekend, and there was a brachiocephalic pseudo-aneurysm here from trauma. There's some bony injuries, presumably some clavicular, potentially some clavicular separation here. But what was interesting was the bronchial tear. So it's a pretty severe injury to have a bronchial tear of this severity. So you can see here the through and through laceration of the, so this is a motor vehicle collision. So must have been a pretty severe injury, collision, to have this bronchial tear. I don't know if I've seen, I mean, I'm sure other people have. I just don't know if I've seen an isolated bronchial tear from a motor vehicle collision without like just extensive injury everywhere. He doesn't really, I mean, it just must have been a massive deceleration injury that led to it. Anyways, they repaired that.
It's almost surprising that there isn't more pneumomediastinum.
There is some, but there's not a lot, right? So there is, but you're right, there's not a hematoma. You know, there's the pseudo-aneurysm here, there's a little pneumo. You know, there's, who knows if that's just probably aspiration from just stuff pouring out with some contusion, but I agree, there's not a ton of pneumomediastinum. I mean, there is some, but not as much as you would expect given that this was a complete transection when they bronched him. Actually get the bronchoscopy pictures.
He does have got a sternal fracture, so
yeah, no, he does. Yeah,
a whole lot of compression.
I'm sorry.
There's a whole lot of compression that went on with this guy. So, you know, I think there's a lot of trauma there.
No, I'm sure there is. I'm just saying that I've seen a lot of sternal fractures for motor vehicle collisions with a lot of other damage. I just don't think I've seen it here with that severity of injury to a bronchus. And one thing they always talk about is cardiac contusion, which we really can't detect that patients develop ECG changes, but supposedly you never had that. But you're right, I'm sure there's a lot of bleeding and shearing of vessels from that injury. What case is this? I don't remember what case this is. No, that's not that interesting, but I can show it very quickly. This is just a patient with rheumatic heart disease who just has a massive right atrium and a massive left atrium. I just for more resonance, kind of showing the different contours between the right atrial bubble and the left atrial bubble, and that the left atrium kind of is the one that lifts up the left main stem bronchus. You can see posterior displacement of the bronchus here from the left atrial enlargement. And just one of the more impressive, I don't want to spend much time on it, but one of the more impressive cases of biatrial enlargement, especially with that right atrium extending, so high up. Anyways, not that exciting. What was this case? Oh, this was ugly. This was a gentleman, I can't remember. He wasn't a drug user, but he developed staph bacteremia and staph pneumonia, which has all these. Just whenever I see bad lung necrosis like this, I always think of staph. But what was really impressive is what happened to him a few weeks later. Fortunately, he died. But you can see that those areas that were necrotic. Now, before there was literally maybe a few areas where you saw a little bit of abnormal vascular dilation. It was actually a better pulmonary arterial study, but now you can see all these just really large mycotic pseudo-aneurysms all over the place from where the staph literally just ate into the pulmonary arteries. So just, another massive one here. So just a really impressive case of numerous pseudo-aneurysms from MRSA bacteremia. And it's really impressive that even on the prior one, it's about 3 weeks, so there was a decent amount of time. Oh, but you can't, I mean, there's really, I'm sure, I mean, I looked and I saw one area you could see a little, maybe like here, that's a little abnormal here, this vessel, but for the most part, all those other areas don't show any of that kind of pseudo-aneurysm change.
Was there a potential source of the bacteria identified?
They weren't really sure.
Wow. That's really bad luck. Oof.
Beth, we've lost your sound.
Seth, can you hear us?
Are you muted, Seth?
Maybe he's lost all audio.
Yeah, I don't think he can hear us. Well, here, I will just,
I'll text him.
okay. Let me try muting him and unmuting him. Seth, can you hear us?
Maybe we could take up a collection and pay his electricity bill.
All right. Well, does someone else want? Maybe he'll get the message if we take control back.
I've got one quick case.
All right.
So this is a case of tracheal amyloidosis that is pathologically proved, and we'll start with cross-sectional imaging. Here we have this very lumpy tracheal wall throughout, and it's interesting that the thickening extends to the posterior membrane, which is one of the things that's supposed to help you distinguish amyloid thickening from, say, relapsing polychondritis, which should spare the posterior membrane, but actually doesn't all the time. The other thing I really like about this case is that we have some of the findings of amyloid that we see in the lung, for instance, and that is some associated calcification or probably ossification here. So some of these tracheal lumps here are actually calcified, probably ossified. So I don't think I've seen that before with tracheal amyloid, but I think some of the people in this conference have shown cases where there were calcific lesions. Am I correct about that? Have you guys seen this before?
Yeah, I think so. With calcification, ossification in the lesion. Yeah.
Yeah, I've seen that heaped up calcification in tracheobronchial amyloid.
Okay, and this person has some mysterious lung disease too, which at this point is not well characterized, but is probably not amyloid. Although when you do see septal lines, that is one of the manifestations of amyloid. There's very little history available on this case. Person, I think, is a cigarette smoker, does have emphysema. So these little holes in the lung are probably part of that. So it's a case of tracheal amyloid with some ossification. And here is the finding on the coronal view. Again, these calcific deposits.
That's a milder case because the ones I've seen have been very diffuse. And I think Julie years ago sent me a case that was like one bronchus, like one lobar main bronchus. But the other ones I've seen have always been very diffuse.
Yeah.
So maybe we caught it early.
Okay. So we should inform Seth that we didn't hear his last case.
Yeah, no, I don't know. Yeah.
We're gonna come back to Seth now. Let's see if we can.
Just real quick, it's a consult. You know, basically this looks like PLCH,
Right.
but the patient is a non-smoker, never smoker, doesn't smoke weed, doesn't smoke anything, lives a healthy life.
How old?
33. No secondhand smoke exposure. And I said, I don't know. It just looks like PLCH. I mean, it's strikingly upper lobe predominant.
Mm-hmm.
I mean, I've seen some malignant histiocytoses give lower lobe predominant lower lobe predominant imaging features like PLCH. I think I've shown a couple of those cases over the years, but this is strikingly upper lobe. I mean, would you guys put anything else? I mean, she's tested negative for all collagen vascular disease markers. She's pregnant, so they don't want to, and she's already had another kid, so she's presumably had this for a while. I'm just trying to think of other things, given that non-smoking. But then she was sending me articles about this MPAC mutation and non-smokers can develop PLCH. I don't know.
Yeah, I mean, it's something like a small percent have sort of the juvenile form where it's more clonal, but
yeah, any hint of involvement of bones or central nervous system, other areas?
She's been I mean, I asked that stuff, does she have any lytic lesion? And they're like, no, she's been completely asymptomatic her whole life. I mean, that doesn't mean she hasn't had something that's been asymptomatic, but yeah, I was just kind of like where the imaging features and the history just don't match. But I'm like, well, the imaging features are pretty good for it. I don't know what else to say. And they think it's PLCH too. They're just not sure why.
I think I've seen many people in their 20s that present with probably a Huntschuler Christian, the malignant kind.
Yeah.
So they should look for mutations in the histiocytes and see if they can pull up the typical histiocyte mutations.
Yeah, they're going to do, more of like she's like 4 months pregnant. They're going to kind of wait because it really hasn't done much in a few months. They're going to wait until she gives birth and then kind of submit her to the more extensive workup. Okay,
yeah, she probably needs a biopsy.
Yeah, no, they're going to do a biopsy. Yeah. They're going to do a biopsy. They were planning on it until they found out she was pregnant. So.
Yeah, I can wait.
Yeah. Okay,
all
guys,
right.
thanks.
Yeah, cool. Thanks for that case. All right, so David, you're done. Let's see, that leaves Peter and me. Peter, you want to go?
Hey, Jeff, I actually don't have anything today.
That's fine. I got some. All right. Let's see here. Okay. So let's start with this case. So this is, luckily my colleague Prashant was working with me today, so we have some interesting cardiovascular cases. So this is a trauma that came in, and the neat finding is this little thing right here. And, when you first start scrolling, you might wonder, is there an aortic injury? But then you'll realize there's nothing else around it. And then if you follow it down, it connects here to the left pulmonary artery. So this is an incidental patent ductus arteriosus on a trauma CT, not an aortic injury, unlike Howard's more dramatic case. So that was kind of a cute one that Prashant had recently. Quick one.
Was there any damage to the pulmonary artery with that, Jeff?
Yeah, not really. And there's no chamber. That LV is a little big, but that's about it. And this was one of these, we didn't know how old the patient was at the time, but clearly looks pretty young. So they'll work that up. This is an interesting case. So this patient has a history of laryngeal cocci. And you can see on this chest radiograph, there's an abnormality on the right. There's distortion. And on the lateral view, there's something going on there. So they did a chest CT, and lo and behold, we can see there's a lot of volume loss. We have a collapsed right upper lobe. And if you look carefully, there's narrowing of the right main bronchus. If we look at the soft tissue windows, whoops, the right one here. Try this. There we go. You can see just what a high-grade stenosis is. And there's even thickening of the lower trachea. And then there's some probably presumably obstructive stuff going in there. So they biopsied this and didn't get any cultures and stuff, but it doesn't surprise me. But what else I should show is there's this scarring and stuff down the right lower lobe as well in this sort of area of consolidation. So the presumption is, and I think it all fits, given that the patient has active laryngeal cocci, that this is tracheal bronchial cocci as well. And I've seen it with Cryptococcus TB, of course, but I've never seen it with cocci. But for those of you who are out west, or we used to work out west, did you ever see this in the airways?
I've never seen cocci produce a stenosing lesion like that ever. No.
I mean, I'm guessing that's what it is because, I mean, if it's in the larynx, I couldn't imagine why it wouldn't be in the other airways.
Yeah.
TB tests are negative just to make sure it's not diseases. Please analyze.
Yeah. And this stuff down here is presumably related to the cocci because, I mean, I see it in a lot of our snowbirds and if people who travel down there. And what I've noticed is the lesions don't always go away, even if they're treated and cleared. So sometimes this stuff hangs around, but that's the presumption. There's no neck CT. There are some laryngeal endoscopy images. They just showed inflammation, a lot of stenosis, but this is pretty tight there in the bronchus. Yeah.
Oh. And
then my last two cases are two cases of the same thing that we have come across recently. And I don't think I've ever seen this, but maybe one at a time. So these patients both have really bad lung cancers. You can see there's this big ugly mass. And this one you can see has invaded the mediastinum and the heart. And you can see here's the left anterior descending coronary artery, and it goes right into the mass and then just kind of gets really thin, and there's a bunch of side vessels. And then if you look down here, I'll change the window, you'll see there's a thrombus in the left ventricular apex. And also there's maybe some decreased perfusion. I know it's always hard on some of these CTs, but it's pretty convincing in this territory that there's some subendocardial hypoperfusion on this non-cardiac CT. So, just a really ugly lung cancer with causing some cardiac ischemia and presumably some hypokinesis or akinesis that led to this thrombus formation. And would you believe it, but this case, I came across this one yesterday. I think I was reading a radiograph. This patient presented, this is an outside study. You can see there's this big, ugly mass here. It looks kind of like our last one, not invading the chest wall, but definitely there. And you can follow the LAD, it's moving, but there's calcifications, and it gets swallowed up into this mass. Now, between this scan and when the patient got here, or maybe it's when the patient got here, they actually coded and was diagnosed with an acute LAD territory MI. And the cardiologist took the patient to the cath lab. They resuscitated the patient and where they were able to get a stent across this. But I don't think anyone at the time even knew that the tumor was probably the cause of this. You can see it's a long stent. So this was a long segment stenosis. And looking at the other coronaries, we see a little bit of calcification, but it's really not like a heavy burden of disease. So these are two lung cancers causing myocardial ischemia, one causing an infarct because of invasion and encasement of the LAD. Here's some nice smoke artifact in here as well. But I think I've seen one case of this ever. I may have been on this webinar. I don't remember. I couldn't find it, but we had these two in same location. And it's just usually the pericardium is so tough that it's unusual to see direct invasion short of coming in through the veins, where we sometimes see it go down the pulmonary veins. So I don't know if any of you have ever come across anything like this.
No, never seen anything like that before. Gosh.
Yeah. So this patient's getting radiation right now and try to reduce some of the mass effect on this one. And the other patient, I'm not sure what they're doing as well, but I presume they would also do not resectable, so it's palliative chemotherapy with palliative radiation for the cardiac invasion. But you can see this one's just taking out the veins, everything, but also the left ventricle is invading it. So, all right, well, that's what I have this week. Thanks for all the great cases.
All right, very
Good
good.
to have everybody back, and I'll talk to you all next week.
All right, bye, guys.
Thanks, everyone.
Thanks, guys.
Yeah, bye.
Thanks.
Bye, everyone.